you eat maybe 6 times a day, at least 2 to 6 times a day, hopefully not 0 to 6 times a day, but in that window. And so for many people, that's much more exposure than you would ever have through a medication, even something over the counter. Now, let's also think about that in terms of protein structure. A normal pharmaceutical would be the size of this versus a plate, which would be the size of this. And so in our lifetime, we're exposed to really a gargantuan amount of antigens, of proteins that our body can either accept or reject. And so while we can control inflammation with medications, we can control inflammation, and that's predominantly the way that it is done in standard of care, there's also an opportunity to control inflammation with the foods that we eat. Now, think about conditions out there, what your docs are dealing with, what their patients are dealing with. Try to think of a condition that doesn't have an element of inflammation. And if you think of one, I might be able to think of a pathway that feeds inflammation in there. But my point is that it's very hard to do. Most of the conditions that we're working with, unlike somebody in acute care where a limb has been lost and the idea is stitch it on and worry about the rest later, unlike acute care, in chronic conditions, i.e. most of our demographic, there's hardly a condition out there that doesn't have an inflammatory process. So now, next step. People come in and they say, hi doc, I don't feel well. What can I do for myself? And so a typical response to that would be script pad, particular prescription, and here you go, you're out the door. But it doesn't answer the patient's question. The patient's question is, what can I do for myself? How can I be empowered about what's happening in my body? And so while they're okay with this, at least as a starting place and to get to somewhere with care, it's not really the ultimate goal they're looking for. So then the next part of the conversation is, how would a clinician deal with this in a reasonable format, the way standard of care is set up? Hello, person. You are asking, what can I do for myself? My answer is that you need to change what you were eating. You need to increase exercise. We need to work on some of these lifestyle parameters. Okay, what should I eat? Right? How many diet books are out there? That we could go pull 10 diet books. They would say 10 different things. We could look at research from vegetarian diets, and we can find some very promising literature. We can even find some case reports of people putting cancers into remission with vegan diets. We can find a wonderful amount of data on a Mediterranean diet. So now, how about a ketogenic diet for certain conditions, or maybe a paleo diet? So what do I eat? And those are all starting places. You have to start with the macronutrition. You have to start with, what are the fats? What are the proteins? Hopefully right up front, what are the vegetables? What are your phytonutrients? And so yes, that platform needs to be established, but we all know that it goes to a next level. We all know in these studies, if we're going to look at a Mediterranean diet or a vegetarian diet or a paleo diet, are you going to find a 100% success rate in each one? Of course not. You might find a 80% reduction in a condition or a cancer, and that would be phenomenal. We would be jumping up and down. Most of them don't give us that percentage because, again, it's not the only thing that people are doing to their bodies. But why is it not capturing all of the population? Well, again, things are multifactorial, not only diet related, but in addition to that diet piece, once we start with the general research, we also have to figure out the N of 1. And the N of 1 is that singular person in the room. So as much as we have data, and we could have outstanding data would be an outcome of 85%, 90%. That's pretty much unheard of in the pharmaceutical world. We'd be happy to see a 30%, a 40%, a 50% response. So outside of pharmaceuticals modulating things, where do we move next? Well, why? Why do they not reach 100%? Because everybody has individuality. And when we began to talk about either hormonal complaints or when we began to talk about headaches or eczema or psoriasis, person A's eczema is different from person B's eczema is different from person C's eczema. There's an individuality there. So that cortisone cream might work 60% of the time, but we're left looking for an answer the other 40% of the time. So start with a good diet. Nobody's going to do wrong to eat more vegetables, unless, of course, you happen to pick the vegetables that you are sensitive to, that your chemistry responds to incorrectly. And think about how frustrating that is for the patient. So here's the patient making these changes, getting rid of the cookies, getting rid of the ice cream, the comfort food, getting rid of the things they're used to. And sometimes it's not even about sugar and that piece of it, but it's about, here's what I've bought when I've gone to the grocery store. This is what I know. This is what I'm used to. I know how to make these things and prepare these things. This doesn't create the same type of stress in my life that something different does. So now there they go. They're ready to create that stress. I'm sure as you have worked with people who are changing their diet, one of the most intimidating times is the first time they're going to go back to the grocery store with the knowledge you have given them. They are fearful and confused, and it's going to take longer. At least that first time, we like to let people know that over a period of time, you'll get used to different foods and you won't have to read every label anymore, but initially, every single label. And those aren't the shortest labels out there to read, are they? They certainly take very careful eye work to make sure that you're capturing what's there. So there they are, making these changes, eating vegetables, doing what they think their doc said to do, and I'm not losing weight. I don't feel better. The eczema is not better. The asthma's still there. The joint pain is still there. And so a couple things happen. Either they say, forget it, diet must not work for me. Well, let's remember stats from places like the World Cancer Research Foundation that says 90% of cancers are environmental. So I don't think it's diet doesn't work for somebody, but it's figuring out what's the right diet for them. So there's that interaction between clinician and patient. What can I do to help myself? No, that's not what I mean. What can I do to help myself? Oh, change your diet. How do I change my diet? Difficult conversation to fit into the standard American visit, which is 7 minutes long. And difficult to answer. Again, different diets, different books, different philosophies. People are different on Monday, from Tuesday, from 3 years to 10 years. So even what they need changes. So how do we get that individualization? A simple blood draw can be an answer to that. And from one blood draw, we can begin to look at least 4 different ways somebody's immune system is reacting to a particular food. So we start with good nutrition as we know it, and then we build from that point. This is one of the areas that I think really has been fundamental to progressive medical, where myself and Dr. Goli work, being one of the largest integrative clinics in the Southeast, is because there is so much attention to diet. And when I first came on board, I was naive, ignorant, probably I'm going to call myself a little more to the ignorance, maybe bratty side to start with. I thought, when people come here, we are going to pretty routinely do some type of detoxification with them, and we're going to do some type of food sensitivity testing with them. And I remember thinking, well, what if I think I don't need that? What if I think the patient doesn't need that? Everything needs to be individualized. Not everybody's going to need to do these things. Well, it does turn out that everybody needs to eat, so eating the least inflammatory diet possible, not thinking that that was necessary, was certainly naive in my clinical position at that point. And in terms of the detoxification piece, when I started incorporating these into practice at large, I began to see my standard therapies work better than I expected them to. The B6 worked differently after a detox. The progesterone worked differently after a detox. And so I think fundamental to Progressive's growth has been that focus on diet. Multiple dietitians on staff. Each time a patient comes in, they meet with the dietitian. The first visit when they come in, we get them started on an elimination diet, and that gives us a way to get things started and get them going. We look at the dietary antigen tests complete, the 588E and the 588G. From there, they get started with their detoxification process and their diet and the pieces that treat the chief complaint. And then when they come back, now we have the next step. A patient is not likely to want to stay on a detox diet for the rest of their life. Now, granted, you're probably going to live on planet Earth for the rest of your life, so there's some merit to that, but it's difficult to do. Where we can figure out what our body is reacting to, what we're inflamed to, what's creating the most immune response in our body. Now the next step at Progressive is they transition from a more generic, but still tailored to them, detox diet to one that's custom for them based on the food sensitivities. And maybe about 3 years ago, we took about 300 charts and we looked at who had positive food reactions. And then we looked at who came back with follow-up tests that looked better. And then we looked to see when that occurred, when food sensitivities and food allergies got better, when you saw those reactions go down, what happened in terms of patient care. On average, we saw about a 70 to 80% response rate to many symptoms, not just irritable bowel syndrome, not just Crohn's or colitis, gas, bloating, constipation, but to depression, to weight gain, to fatigue. Now, granted, in that study, we were embracing not only food elimination, but we were looking at doing gut repair, doing some treatments that are very common for us to do here at Progressive Medical. So it was certainly twofold: remove the foods and work on building the gut lining, but really seeing impressive results when we did that piece. And those are published results that we are happy to share. So if we can think about the exposure people have to food on a day-to-day basis, and if we can think about how this gives them the opportunity to reduce inflammation in their own body through their own empowerment, through their own knowledge, you know what? It even gives them the opportunity to create inflammation with their own knowledge and their own power. And sometimes that has meaning too. I'm going on vacation. I know I'm going to do this. At least I know the next day why I have the headache. It's no mystery or no surprise. So regardless of what we choose to do with our knowledge, it's there for us to do that with. And that's, of course, true. People aren't perfect and people will stray, but if you see that you got better when you took things away, and then even that next piece, I got worse when I added them back in, it makes it very compelling, and it puts you in a position of, well, compliance, for lack of a better word, that these are some choices that we want to make. Okay, well, we know there are common foods that are more likely to be antigenic. We know that foods like wheat or dairy or peanuts or soy, corn, and oranges are all things that will top out the list in terms of antigenic potential. So why don't we just remove those foods from the diet and see how people do? And certainly, Progressive embraces that. That's part of that original detoxification program. But you'll many times see people come back reactive to chicken, reactive to coffee, not heart palpitations, not the caffeine from it, but I'll share with you a story from a colleague who said that, this colleague, first of all, called up, upset, Cheryl, have you had any problems with your food sensitivity testing recently? And I was like, you mean like to coffee? Because for whatever reason, the test had happened to pass my desk, and because he's a friend and a colleague, the name stood out to me. And because I know him, the fact that coffee was something that was coming back as a reaction made me chuckle a little to myself. Okay. And so then he calls and says, any problems? I'm like, nope, no problems with coffee. The result is true. He doesn't really believe it, but he says, okay, fine. He takes coffee out, and he says, if I'd known what I had known from this test years ago, it would have completely changed my medical trajectory, because I wanted to be a surgeon, but I could never make it through scrubbing in and being in there. I had such urinary frequency that just wasn't a reality for me. Now, in the end, I guess it's a good thing he didn't know, because he's a wonderful functional medicine practitioner, and we would hate to not have him in the realm that he's in right now. But the point is that we all have an attachment to certain foods and things that we like, and sometimes it takes seeing it on that piece of paper to make it real for us, to make it actionable for us. From there, just like we would experience with ourselves and our families, then he was like, I need to get the rest of my family to do this testing as well. And in his wife, that there was a positive for gluten. As that was removed, a long blue fog that had been over her was lifted, and so on and so forth with other family members. And so that is why people do this kind of testing. They do it to get better. They do it because it works. And so that is certainly something that we have seen here at Progressive, and I think it's really fundamental to the growth. If we can give people knowledge about their bodies and knowledge about what they're eating, and a way to be empowered about whether or not I feel good, or maybe I'm going to choose to feel bad for half a second, then I think that is truly what people are here for. I believe that people are not necessarily here for any particular procedure, for any particular pill, powder, or potion. I believe they're here for education, and to take that and to make that next step, and to move to wherever they would like to. And so when I talk to patients, I talk to them about how The gut is the size of a tennis court, and many times you have to back up and even explain what the gut is. That's not common terminology for everybody out there. So a couple of a friend, her teenagers, heard me on the radio, and those they're very smart teenagers, AP this and advanced that, but they were like, "What's the gut anyway?" So it was a reminder to me that something that feels so familiar is not always so familiar. So when we're talking about the gut, essentially we're talking about the entire tube from top to bottom. We're talking about the mouth, the esophagus, the stomach, the small intestine, the large intestine, and the rectum. And so when we take all of that area, if you were to stretch it out, it is larger than a tennis court. And I think this point becomes really useful to patients. It really helps them to conceptualize, well, wait, your test says I only have a 3+, and the top of the scale is a 5+ to gluten. So can't I just eat some gluten, some wheat? You say, well, do you want a little bit of inflammation? Do you want a little bit of irritation, some irritation all over something the size of a tennis court in your body? So it helps them to see how even a little bit of exposure, maybe not every day, less frequently, could still have an impact in the system. In fact, some of the research suggests that as much as 3 months after an exposure, you could still be having an immune reaction to that food. So when somebody is doing a detox diet or an elimination diet and they say, well, I'm just going to have a little, for some people that's okay, but for some people it can really still be that stimulus that keeps the immune system on fire, keeps the immune system on hyper overdrive, and keeps the immune system in a state that moves us away from cancer prevention more towards autoimmunity or even just immune suppression. So what are we looking at when we look at these food sensitivity tests? Well, we're looking at some antibodies to foods. We're not looking at all antibodies to foods. And how did we decide what to look at? I hope, and I think that the fundamental reason that we always decide to look at what we look at is because it's well represented in the research, that it's well represented in the data. Some people will argue that that's not the case, but I would disagree. So for example, if you go to PubMed and you begin to look at what are the foods, what are the immunoglobulins, what are the known immune responses that are going to be most aggressive, the area that you're going to find an immune response, the area that you're going to find the most research is probably in the realm of IgE. So IgE are allergies. This is that immediate reaction to things. And this is a semantic game that sometimes you see clinicians get hung up on. We have defined IgE as allergy. So therefore, IgE is the only allergy. What is the rest of this? This is not an allergy. Fine, concede. It is not an allergy. But it doesn't mean that it's the only way that foods can cause our body to react. It is one way that our body will react to foods, and it's the way that people are most familiar with. You can do this a number of ways. You could do it through a blood draw, but you can also do it through a skin test. You prick the skin and you see if you get an immediate reaction. So many times people will say, well, maybe I don't need that test because I've already done that. I had this done to me once, and so I don't need to do that testing. Well, that's not accurate because this testing can only pick up an immediate reaction. So in the DAT, the dietary antigen testing, we also look at IgG. Now, even within IgG, there are multiple subtypes. There are multiple pieces of IgE. And even within this category, you can have a number of different reactions to foods. And in fact, within this total category, some of those subtypes are much more likely to cause inflammation, and some can even block certain types of allergies or inflammation in the body. So we measure IgG and IgE because this is where the most data is around food and food sensitivity. But we also measure some other immune reactions to foods, including complement, which can activate other parts of the immune system, the complement cascade, either the classic cascade or alternative cascade, and we'll get into that in more detail. IgM is meaningful, but this is what happens immediately. And so probably when somebody comes to us, we're not as with a chronic condition, we're not as concerned about the symptom that they got yesterday or the day before, and that's when you would have an IgM reaction to foods. This is what happens first, immediately. And within a short period of time, 3 weeks or more, you begin to seroconvert and you split. You can either go to IgG or IgE from here, And so these are going to be associated with something once you have been symptomatic to it for a longer period of time, more than just a matter of weeks. IgA found more in secretions, so usually it will be more localized in the gut or the GI tract. Now, that's not entirely complete in and of itself, but it will stay more bound to stool. So if you were going to measure an IgA reaction to foods, probably the better place to do that would be in stool. And because we find blood to be more convenient and a little easier to get your hands on, that creates a terrible visual right there, but stick with me. That's why we move towards these directions. Now, not entirely true. There is some exchange with IgA in the gut from the lumen into the serum, so nothing in the body is fixed. This idea that here's the gut, and maybe you make serotonin, a neurotransmitter in the gut, but that stays in the gut and does nothing else. Well, now we learn you actually absorb that. Now we learn there are transport mechanisms on the blood-brain barrier. So this idea that what happens in this organ doesn't affect another organ is really an incomplete idea, and probably something that integrative medicine works to address. Isn't it mind-numbing at times to watch a bunch of specialists bounce around off one another? If you were just looking at those systems together, you would see how one affected the other. Recently, somebody in my family had an experience with congestive heart failure and liver failure, and because they were so busy looking at those things separately, they couldn't figure it out. Way before anybody at the hospital was saying anything about this, Dr. Agoli and I were saying it's probably viral, something happened in the heart, the damage there is backing up and affecting the liver, but it's just natural for us to be looking at these systems together. After a couple weeks in intensive care, they came to a similar conclusion, but it can certainly be frustrating to watch the body be broken into these reductionist pieces and not be addressed as a whole. So, in terms of structure of what these pieces look like, they also act differently in the body. Typically, IgG and IgE pretty similar, so here's where they will bind to a food and either create an immediate reaction, anaphylaxis, hives, shortness of breath, or a delayed reaction, 3 to 72 hours later, and in general, increasing inflammation in the body. Well, again, what is inflammation? Is inflammation what I feel in my knee when it hurts? Yeah, but do you have to feel pain to have inflammation? Absolutely not. Think about other inflammatory markers in medicine. Think about a C-reactive protein. That's an inflammatory marker. You don't always feel it. Think about homocysteine. That's an inflammatory marker. You don't feel homocysteine. It increases your risk of heart disease, maybe kidney disease and dementia, but you don't feel it floating around in your body. So many patients, when they get back food testing with high levels of IgG, and we say, well, this shows inflammation in the body, they go, but I don't hurt. My stomach doesn't hurt. My arm doesn't hurt. This test can't be right. Many times we will feel inflammation, and absolutely these reactions are associated with joint pain or circles under the eyes or headaches or things that do result in pain. But you can also have the situation where inflammation is washing over your genetics to cause your genetic weak spot to be exposed. And so inflammation can cause more exposure of autoimmunity. You don't hurt until you get there. But so think about that in terms of when people say, yeah, but I don't feel this in my body. Well, you don't always have to feel inflammation. Many times you will, but that is a possibility. So these are delayed sensitivities, 3 to 72 hours after you have something. And this is why they really lend themselves to testing. So if you can react to a food 3 to 72 hours, and anywhere in between, and probably a little less and probably a little more if I know the human body, because it doesn't like to stick to these rules that we give it. There's always going to be someone that makes a liar out of you when you do that. So if we talk about these 3 to 72 hours, and today I had an egg, and that inflammation happens in 6 hours, but yesterday I had a blueberry that I'm sensitive to, and that reaction happens in 12 hours, but tomorrow I have an orange, and that reaction happens in 2.5 hours, and then finally that day I start to feel lousy. I'm going, must be the orange, because that's what I just had. Well, it's a little bit the orange, but it's the blueberry and it's the other piece too. And so it's very confusing just from a clinical picture to get an idea of sensitivities. Sometimes you'll even hear people in our community say sensitivity testing is more important than allergy testing. And so that's a toss-up because you can die from anaphylactic reaction, so that has to give it a pretty high degree of importance. But the reason people will say that is because an immediate reaction is easy to figure out. If I eat a strawberry and my lips swell, I got it. It was the strawberry. And so sometimes people will say the testing's not as important because you can figure it out clinically. You can miss things too. So I'm not necessarily conceding that's the case, but the reason people will say we need more sensitivity testing, I think what they're trying to say is that it's harder to get from a clinical history alone. And so if we can add these pieces, now we have something that meets the need. There's the doc, there's the patient. What should I eat? The doc has no idea because we have no idea what each individual should eat unless we're testing and looking at their body. And so now, rather than trying to explain the distinctions between a vegetarian, a vegan, a Mediterranean, a paleo, and a ketogenic diet, and there's probably more that I'm leaving out that I should be including in this discussion, now I can say, let's do a blood draw and let's see what your body's reacting to, and then let's tailor a diet to what's happening in your bloodstream. That's a very manageable conversation. Some pushback that we get is that there are certainly docs out there that don't want to talk about diet, that don't want to talk about foods, and that's certainly a reality. But I think more and more people are going to have to be involved in this conversation because even if they don't want to be involved, their patients want them involved. And when you don't give me an option of something I can do for myself, then I'm going to go find another doctor. So I think that is why we see functional medicine practices really thriving. And when I am here at Progressive or travel around the country and see the places that are really growing, and when I look to see what is the rate limiting factor of their growth, the thing that slows them down is having enough doctors, having enough clinicians that practice this kind of medicine. The fast-growing clinics, that's always what they're looking for. That's why they're looking for training programs and looking for ways to where to even find people. And so there's a need for this. And there's a need for people that are doing this. And so we're positioned in a very lucky way in that it's not in any way a saturated market. How many of you, the last time your relative was sick and they went to the doctor, they had a conversation about what they're eating? Yeah, right? So that demonstrates it's not a very saturated market. And there's a lot of space for us to be talking about this and a lot of opportunity to help people. So a basic kind of breakdown and some difference. IgE, that fast response, few minutes, a strong response. There's some that we call it more like a blowtorch, acute and powerful. And this is a nice way to think about it. Essentially, whether or not it's a food allergy or sensitivity, the immune system has become confused. The immune system thought it was something more like a bacteria or a virus, and it's fighting like it would fight a bacteria or virus. That's great. If you want to kill something off, make a lot of free radicals, have a lot of activity in terms of inflammation, that will kill bugs. However, I don't need to kill broccoli. I don't need to kill spinach. I don't even need to kill a bagel. And so when you start to fight foods as if they were a bug in the body, you can see why this creates an ongoing problem. First of all, if you continue to eat that food, that confusion for infection never goes away. So now it's like you're fighting an infection lifelong. And at the same time, you're doing damage to the system. And so both do that. It's just a matter of whether or not they're doing it quickly or in a more delayed response. And yes, maybe weaker, but that's probably in some incorrect language because is this an example of a weak response? So here's the example. So a patient presents here. She's about 14 years old. She has a condition known as costochondritis, but hers was very severe, so inflammation in the ribs. And at this point, at 14, she's on a cane, and she is on a lot of pain medication. She was being seen at Emory, and her mom was, in fact, a pediatrician at Emory. Her mom thought, you know what? I don't know, but maybe there's something more for my kid than pain meds and a cane, because what Emory was saying the next step after that was more pain meds and a wheelchair. And so she thought surely there's something else that could be done. So she leaves Emory and comes to Progressive. I can only imagine what colleagues said, but we're actually, Progressive Medical is an approved residency site for Emory. So more and more acceptance in terms of what we're doing because the research backs what we're doing. So kiddo comes out here and we get started and she goes through the detox diet. She hates that. You know what a detox diet makes a 14-year-old do? Not eat pizza. How realistic is that? Not that realistic unless you're in chronic pain. So she dabbles with eliminating it. she takes it out a bit, and then she cheats again. But then mom makes her take it out longer, and then she cheats. But as she's taking it out, her pain medication dose is not going up. It's staying consistent. Oh, and as she goes to that spend the night party and has that pizza, she really hurts the next day. And so it wasn't too long. I mean, maybe longer than we might expect, but 6 months, 9 months before she was completely off the gluten. And when she was completely off the gluten, that was found in the food sensitivity testing, not an immediate reaction, but what's being defined as a weaker response. When she was taken off those delayed sensitivities, which gluten was a big one for her, I talk about her walking around as a normal teenager now, which means walking around like this, texting, not walking around on a cane. And so while, yes, you're not going to go into anaphylactic shock from this type of response, to classify it as weaker depends on which type of antibody is creating the most harm in your system. And so for that kiddo, I would hardly say that's a weak response.
Better now?
Yep. 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 And if she cheats, then she feels it. But because the inflammation has slowed down enough in her body, she can cheat a little here and there. But in general, she doesn't want to because it's not worth it. Another question out there is, how long does it take till normalization? And so some people say that we always have IgE antibodies, but the research says a little bit different than that. So for example, when they looked at the half-life of IgE, 1 to 5 days, so why do we think that people, once they have an allergy, will always have an allergy? Well, that's not the entire story. So if that IgE antibody gets attached to one of your immune cells, like a mast cell or an eosinophil, now it can hang out in the tissue for even months and months and months at a time. But there's always a genetic variance here. So even though we have these rules of thumb, why isn't it just 5 days? Or why, even better, why isn't it 5.3 days? Because it's not exact. That's why it's 1 to 5. And so you'll find people that are just genetically predisposed that those titers stay around much, much longer. Also, it's because it's a difficult question clinically to answer. If I have a kiddo that was anaphylactic to a peanut, and last time he did it, he had a shortness of breath that ended him in the hospital and was almost incompatible with life, when is it that I want to reintroduce that peanut? Look, for myself, I get some pretty bad stomach issues from a crab. And so even though my titers aren't there anymore, I'm still like, when is a good time for me to reintroduce this and see if this is going to hurt like the holy bejeebies in me? Because I don't necessarily have 48 hours to sit around in pain too often. And if I did have 48 hours to sit around, I still don't necessarily want to do that in pain. So that's why we often hear that once an allergy, always an allergy. Because clinically, when do you re-intervene? And IgG, in terms of their half-life, longer. So subtype 1 and 2, 21 to 24 days, and subtype 1 makes up 60 to 70% of our IgG antibodies. So they'll hang out longer, it takes longer to calm down, and this is why we'll often instruct patients to be off these foods for 6 to 9 months before even doing some type of reintroduction based on how aggressive the symptom is. Okay, so let's actually look at the test. So this is the first page, and actually in full disclosure, I often tell the clinician to go to page 11 to start with, because that's where the summary of results is. But let's go through the test in order, and then when we get there, you'll see why that's often such a great place for them to start. So what is it that you're looking at? Well, on page 1, you're not actually looking at their individual allergies or sensitivities yet. And so we start off with the 588E. It's named 588E because that's the IgE portion. And so IgE is this allergic reaction, this immediate response to foods. And so we start there, we measure that, and then on this first page, what you see is you see a tallying. You see an addition of how many and how much reactivity they had in a particular food family. And so this addresses the fact that you can never test every food out there. Well, you could, but you'd create a test that was probably $5,000, the same price as Carlos Packets back there, and then people would not have any money left to spend on treatment and or transportation, a roof over their heads, and other things that are probably good for quality of life. And so rather than test every single food, what we did is we took the 50,000, we used to test many more foods, and we looked at our 50,000 specimens. And from those 50,000 specimens, we said, where is there still a high level of reactivity? And it was pretty clear that you could draw a line, and after a point, you saw about only 1 to 5% of the population ever come up with those at all. And so it made good sense to limit the foods because certain proteins and certain foods are more antigenic and others are less antigenic and others we have less exposure to. For example, we had somebody call Dunwoody Labs and ask if we could add camel milk. And while we could certainly add camel milk, there's not really a great reason to do that because not too many people, especially here stateside, consume camel milk. So we could charge everybody for looking at camel milk, but does it make good sense for our population? Not so much. So if statistically people don't really react, then we decided a much better thing to do would be to decrease the price of the testing so that it could reach more people and capture the things where people have really more exposure to. However, the flip side of that is you lose some things. What about that person that is, reactive to acai berries or something like that that might not show up on here? And so the answer to that is to say, first start with the individual reactions you come back to, which will be the next pages. But then, if you don't get the reaction you would have expected, go back and look at which family had the most reaction and do a trial of taking out that family for a period of time and seeing how the patient does. So that's the first part. That's IgE, and IgE, this always looks like doop, 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 something on CNN that I don't know, it's one of those CNN graphs that you never really understand exactly what they're to represent. But here, the yellow is your reaction, your allergic reaction. That's your IgE. And so the blue is IgG subtype 4. Okay, so it already starts to get a little tricky, and that's because scientists are bad at naming things. They just look at kind of a structure and a shape, and if they kind of look alike, then you're IgG1, you're IgG2, you're IgG3, and you're IgG4. What you do in the body might not be that similar at all, but you look similar. So we're just going to call you all George, for example. And so we have our 4 Georges running around, but IgG4, very, very different than IgG1, 2, and 3. So predominantly, we make 1, 2, and 3. Between the 60% that's IgG subtype 1 and another 20 to 30 that's IgG subtype 2 and 3, just very minute amounts of IgG subtype 4. And it has a very different purpose in the body. IgG subtype 4 is not very good at creating inflammation. It's not very good at creating a delayed sensitivity. What I need to have happen to release histamine, to have a mast cell degranulate and a white blood cell create inflammation, I need to have that food come and bind to that IgE antibody. And it's like a key in a lock. It opens it up, pshoo, the cell opens up, releases histamine, you create an inflammatory reaction. And so so I've got to have that food bind, but then I've also got to have that whole combination slide into the cell, the mast cell or the eosinophil that's then going to burst apart. So you put these two together, and then if they attach, now your white blood cell bursts apart and creates histamine. Well, so if you put these two together, but what if the IgE can't get in there? What if something else is already there first? So it turns out IgE is kind of a big clunky key. It's hard to get in the lock. You might have had some locks like that at your house. You're doing this all the time to try to make it work. Well, IgG4, smaller, better, more tightly cut key, shoop, right in. And so the IgG subtype 4 can get into that receptor much more easily than the IgE. And now it's already there. So now when this tries to go and bind to that cell, it's blocked. IgG4 is taking up the slot, taking up the hole, and it can't get in there to do its job.